I'd like to thank the General Thoracic Surgical Club for giving us the opportunity to present our work. The title, as Dr. Blair had mentioned there. And so some background, esophagectomy is a complex procedure that has been associated with significant morbidity and mortality. Despite improvements in surgical techniques and improved perioperative care, significant morbidity and mortality rates persist. Improved patient selection provides an additional way in which postoperative adverse outcomes may be minimized. Risk profiling is used to identify patients at risk for adverse treatment outcomes for many diseases and can be used to assist with patient selection. Our group previously validated the age-adjusted Charlson Comorbidity Index as a useful risk stratification tool for patients undergoing elective MIE. The purpose of the current study was to improve our prognostic model by identifying additional preoperative risk factors that impacted adverse postoperative outcomes in patients undergoing MIE. This is a retrospective review of 1,033 MIEs performed between 1997 and 2011. Patient characteristics, treatment details, and postoperative outcomes were abstracted from our prospectively collected database. We excluded patients who underwent non-elective MIE, as well as patients who had missing data for any of the variables used in the multivariable logistic regression analysis and final model. We look at the outcomes of in-hospital and 30-day mortality, 90-day mortality, extended length of stay, which is greater than 10 days, and major morbidity. As you can see, our definition of major morbidity was quite extensive, including a number of pulmonary, cardiovascular, and other complications. So first we performed a univariate analysis to determine the associations between pretreatment variables and postoperative major morbidity. An a priori cutoff value, p-value of 0.2 from the univariate analysis was used to select variables for inclusion in multivariate logistic regression analysis. An a priori cutoff value, p-value of 0.15 from the multivariate analysis was then used to select variables for inclusion in the final prognostic model. The prognostic model created using the outcome of major morbidity was then used to predict outcomes for 30-day in-hospital mortality, 90-day mortality, and extended length of stay. Model discrimination was evaluated by calculating the area under the receiver operating curve, and additional diagnostic testing was performed to determine the accuracy of the model. Here you can see the frequency of the adverse outcomes. 30-day or in-hospital mortality was 2.8%, and 90-day mortality was nearly twice that. Prolonged length of stay, 37% of patients had a prolonged length of stay, and major morbidity occurred in 43% of patients. As you can see in the next column, clinically significant anastomoscopic leak occurred in 12% of the patients, and the frequency of the remaining complications below. So this is a big table. This shows the variables included in the risk analysis. There's actually two slides as we looked at a number of independent variables. In the first column are the variables, and then the second column shows the prevalence within the population, and the third column shows the frequency of morbidity in that subgroup. To the far right is the results of the univariate analysis, and highlighted are the p-values that we included that were less than 0.2, which we included in the multivariate analysis. You can see age actually didn't meet that criteria, but we did include it in the model, as people have shown previously that age is a significant factor for postoperative adverse outcomes. Here are the remaining variables we looked at. In the center here is the age-adjusted CCI risk group, which we had previously broken down into low risk, moderate risk, and high risk. We used the risk groups for the final model, but we did, in univariate analysis, look at the individual CCI variables, and you can see the majority of them were significant. And here shows the results of the multivariable logistic regression analysis. In the first column are all those variables that had the p-value of less than 0.2 in univariate analysis. And then the second column shows the results of the logistic regression. And these variables here on the bottom did not meet criteria for inclusion in the model, so they had a p-value of greater than 0.15. As you can see, induction therapy, prior chest or abdominal surgery, and male sex did not make it into the final model. Those that did, age, we forced in, extreme BMI, history of GERD, which was actually protective, prior esophageal surgery, increasing CCI risk group, neurologic disease, and increasing ASA score were included in the final model, with the age-adjusted CCI risk group being significant, or the most significant. So we took those variables in the model, and we looked at major morbidity and determined the discriminatory accuracy by looking at the area under the ROC curve, which was reasonable at 65%. We took those same variables in the model and applied it to the outcome of extended length of stay with a discriminatory accuracy of 65%. And And then we applied them to the outcomes of mortality. 30-day, the discriminatory accuracy was 76%, and for 90 days, 71%. So good to excellent discriminatory accuracy for the model. Some of the limitations of the study, this is a retrospective study, and of course this is coming from a single institution specialized center. And we did not include physiologic variables such as PFTs, ejection fraction, albumin, all of which likely have a significant impact on risk of adverse outcomes. In summary, excellent outcomes after MIE can be achieved in the majority of patients. Preoperative extreme BMI, prior esophageal surgery, history of neurologic disease, as well as increasing age-adjusted CCI and ASA scores were associated with significant increase in risk of adverse postoperative outcomes. A history of GERD was protective, and age did not appear to be a significant risk factor in our patient population. The current model provided good to excellent discriminatory accuracy for all 4 outcomes. In conclusion, use of risk stratification tools such as the prognostic model presented here may be used in the preoperative setting to improve patient selection and inform patients of anticipated operative risk. Use of risk stratification models can also facilitate comparisons of outcomes across centers and should be further explored in future studies. External validation of the current model is needed. Thanks.